I do not have a question, but I have a remark to you, Dr. Márcio. You forgot to mention that patients with seizures, grand mal, epileptics, are easy candidates for the Latarjet procedure. They are not candidates for only Bancari stabilizations.
Yes, please.
It's not a question. You forgot in your presentation.
Just a comment. More important than that, this kind of patient, usually the Latarjet procedure sometimes is not the best option. Doing an iliac adenine procedure is a better one for this kind of patient. There is only one published report of results in Latarjet procedure in epileptic patients. Is from Julius Walsh, showing that the results are not so quite good, and the success of the results depends if the patient has the seizure controlled. This is and this kind of patient, usually sometimes I prefer to use the iliac graft, not a Latarjet.
Thank you.
I have one small comment on this. Relating to the session we just heard about tramadol next door, I wonder if any of the shoulder surgeons are seeing any tramadol addicts. Tramadol addicts, addiction? No, okay, we're actually writing this. This should come out soon, but in Egypt we have surprisingly a large number of tramadol addicts, and as shoulder surgeons we've been finding they get convulsions, and they get exactly like the epilepsy patients. So we have recurrent dislocation due to tramadol addiction. And as you just mentioned, all of them we go for Latarjet. We don't try any.
Anybody have any case of tramadol addiction? Adição com tramadol? No? I have one patient, but not for shoulder surgery.
We have lots of patients because we deal with this motorbike guys.
Okay.
We have a lot of these patients have addiction or drug addictions. They should be treated like you said.
I'd like to discuss with Márcio my opinion about seizure. My indication, especially of these people, is Latarjet procedure. Why? Because I think the Hatem procedure, the iliac crest, is the last procedure. If you have a recurrence after the Hatem procedure, to change for a Latarjet procedure will be very difficult, and even the possibility to success will be not so great than Hatem.
I agree with Gleison. It's difficult to speak the best treatment without a case. It depends about the bone lesion. If the bone lesion of a seizure person, it's like a small one, I really believe the Latarjet is a very good option. The problem is that sometimes this kind of patient, they have a very big lesion of the, usually more than 30%. And sometimes we could discuss to do a Latarjet as in the lying position or flipping the graft so we can have a more surface. This is another discussion.
Marius.
Just a small remark for our colleagues in the audience is that most of the seizure patients have posterior dislocations.
Yes.
So just be careful not to make equal in your brains. Instability from seizure needs Latarjet or Bancari because a major part of these dislocations are posterior. In this case, the most important thing is to make sure about what ligaments are ruptured and what defect you have to fix. Because if you want to make a bone block for a posterior instability, you make your patient worse. And if you want to make a glenoid enlargement or a remplissage, you have to make very, very sure about the direction where the shoulder goes. And the most accurate thing when you do arthroscopy is to test them under anesthesia, of course.
Marius, why you said Latarjet only open surgery?
For me, I was also tempted, like everybody here in the room. I will tell you, it's not funny, but it's a story, you know. So we had a course in Europe because we started to do Latarjet with an arthroscope because we want to do everything with an arthroscope. And now many surgeons go back to open in different cases. Like in my case, I'm quite comfortable with arthroscopy, but for manual workers with cuff big tears, I do open repair because I feel more comfortable and I have better results in manual workers, young, with cuff repair, doing open. But the major part of my repairs are arthroscopically. But what happens with the Latarjet is that everybody was doing Latarjet like they were taught by the school from Lyon. And everybody was doing like Gilles Walsh. And one day we started to do with an arthroscope. So we developed tools to do that. We put more pressure in the joint because we are working in some spaces that are not articular but abarticular. And we succeed in doing Latarjet with an arthroscope. And then when we started to ask from the surgeons who are doing that, they had about 20% incident and problem rate. And then we have been, I was not in that course, but there was a course in a part of Germany, and a very nice and skilled surgeon was doing Latarjet with an arthroscope on a patient, a sports guy, football, 26 years old. And what happened? A screw went out, the engine was turning, and there was a lesion of the brachial vein, one of the brachial veins. So it was flooded by blood, no more view, so they stopped the procedure. They asked from the vascular surgeon came, they fixed, so finally that football guy who came for a 1 hour procedure, for a minimally invasive procedure, wake up 4 hours later with a blood injury, a vascular graft, and a very difficult situation to deal with. So be careful about doing Latarjet because you have to be your first orientation is not to harm your patient. So this is what the story about the Latarjet.
Great. Are you agree with this?
For me, Latarjet is essentially a surgery to do in an open way. In the last 25 years, I am doing Latarjet procedure, Latarjet patch procedure, as Márcio showed. The most difficult step in the surgery is adequately expose the graft to make a coracoid osteotomy and to make possible to mobilize the tendon in the graft. And under arthroscopy, for me, is almost impossible. It depends a lot of the experience and the skill of the surgeon, but is not a reproducible method for arthroscopy. In my opinion, is a surgery only for open surgeon.
Anybody will talk about this?
We are too old to learn new techniques, you know, for you and me.
Okay.
That for the young people.
Talk about bone fractures, bone-calf fractures. How is the best way to do the diagnosis? CT scan, MRI, arthrography?
No, I think that the best is CT scan for me.
CT scan.
CT scan. Of course, it's possible with the strike position and an X-ray, and with some type of X-ray, it's possible to see the glenoid fracture. But
the decision is with the CT scan. Okay.
And also, it's very important for Latarjet. When we see the reverse pier, I think that this is a complication of a fracture of the glenoid that was under diagnosticated. The bone is resolved, and then we have the reverse pier. That's the reason, because we have to study with CT scan this patient, because at first it's possible to fix the fracture of the glenoid, but then if we have a reverse piers, we have to do a Latarjet.
Okay, I have a case to explain to you. One patient, 6 years old, female. Yes. He had proximal humerus fractures, 3 parts, dislocation, and glenoid fractures, okay, 1/3, and came to you after 24 hours. What to do?
Oh, it's,
Well, but I have to explain the fracture. Dislocation, 3 parts proximal fracture, and the fracture 1/3, but the rest of the joint, just the cartilage and the bone, the subchondral bone, go together with the anterior fragment, but completely, I don't know how to say esmagado, crash? Smash, okay? Completely destroyed. The cartilage is destroyed, okay? 1/3, dislocation 24 hours, 60 years old.
I sent the case to you. Well, it's very difficult, the treatment. Of course, I think the dislocation is first. It's necessary to reduce.
They try to reduce in small city and came to the big city after 1 day. It's still dislocate.
Yeah.
Okay, it's still dislocate. Under anesthesia, they try to do the reduction until dislocate, come to another city, and then arriving to Santiago to you.
Well, of course, this is not a case for arthroscopy reduction of the fracture. Of course, it's necessary to open and to reduce. And
what you do first? Glenoid, humerus?
Well, I think that in this case, by open, it's necessary to do the both, to reduce the glenoid because it's open. If you reduce only the humerus and you say
the first step, humerus or glenoid?
Well,
because 3 parts fracture.
Well, maybe I think the first is the humerus.
Humerus fracture. I agree with you. I did that.
Mm-hmm.
And after that?
And after that, if it's possible to reduce the glenoid and put a screw, it's a big.
Yes.
It's not the fragment is not so big, and
it's not so big, but not just one fragment.
Yes, it's
no more cartilage.
Then it's not necessary to treat the glenoid. If reduce and the fracture of the 3 parts and the glenoid is possible to treat by orthopedic treatment also.
Some screws.
Like the type 6.
Yes,
type 6 of glenoid fracture of Heidelberg is not necessary.
Loses some part of the anterior glenoid after you fix the humerus.
Yes.
Became unstable, continuous unstable.
Well, then it's necessary to operate the heel sacks, the bunker, the type bunker lesion.
Or Latarjet decision.
With Latarjet.
Anything different? Jacinto, please.
Eduardo, I'd like to know, I was very curious about your theory that you treated arthroscopically the scapular fractures. Of this theory, how many of these patients they had only a single fracture? Because the majority of the scapular fractures are involving polytrauma patients. And, but in your theory, that you treated arthroscopically, how many of these did you treat arthroscopically, or how did you find them?
Oh, yes.
Eduardo, just a moment. Let me finish this case, please. After that,
which one?
I am finished the case, and then okay. Later Eduardo answer you. After 1 year, this patient, I did the 1 Latarjet, okay? After 1 year, with locked screws, I have the avascular necrosis and the screws out, okay? It was so nice, but the screws inside of the joint now begin to have a pain when you do any movement. And then the question is now, I don't have the x-ray, you have just imagine it, okay? What to do now, 1 year after with avascular necrosis? The glenoid is good, no more dislocation with the Latarjet. Okay, But now I have the screws inside of the joint.
When then it's necessary to remove all the the material, the screw.
And go to replace or not?
And then a prosthesis, maybe a prosthesis.
6-year-old, okay. And you, Marius?
I would not put a prosthesis in a 6 years, 7 years old with pain and everything, because our experience with humeral head necrosis is that many patients are asymptomatic. I mean, you have fantastic x-rays with flattened head, necrosis. We have, even in old people with fractures, they are treated with a plate or nails, and they develop necrosis, and they develop it very, very late, usually, after 4 or 5 years. So it's this one year necrosis in a 6 or 7 years old is probably more a problem with the growth cartilage necrosis or disease, and in this case I would just remove the material and do some exercise or to teach him how to do movements and wait and see him again.
You did that, like you said. Now 2 years after, just take the screw and the plate, and no more pain, much better than now, and wait for the future for maybe replace. But for why she don't like to do replace. Now please can you answer Mr. Monteiro?
Well, I operate 6 open glenoid fracture, 6. And the other by arthroscopy. Of course, if you see the casuistic 6 glenoid fractures of type 1. Type 1 is with luxation, dislocation, anterior or posterior. And the other case with type 5 or type 4, in some of these cases, of course, we have more problem, as I showed, with complication, different type of complication. But we tried to operate the glenoid quickly. If you don't operate the glenoid between the 1 week, then it's very difficult to reduce, because the type of bone is fixed, and then it's difficult to move. If we have a patient with many complications, well, of course, it's necessary to treat the lung, it's necessary to treat the other part of the body, and maybe he lost the opportunity to operate the glenoid fracture.
But Eduardo, as you mentioned, these fractures are very, very seldom that you can see them. In my hospital, I remember in the last year, maybe one, in a concept of a polytrauma patient. And some of these fractures are neglected because people is more aware about femur, bifemur fractures, pelvic fracture, and so on. And sometimes only in a 2 weeks' time, you will see, there is also a scapular neck fracture. So I wonder a bit, because this is not a single fracture. At least in my experience of my hospital, this is a fracture that, in the majority of the cases, is involving in a polytrauma fracture. Is this your experience?
Yes, I work in the Del Trabajador Hospital in Chile. It's a worker hospital of trauma. And of course I receive the workers, and many cases, and that is the reason, because I have 18 cases. This is not common, this type of fracture, as I show. And we study, we have a protocol, and we study the polytraumas, and of course, if it's possible to operate all the complication or the fracture of the patient, we have a protocol to treat it. Then these 18 cases, as I show, is many cases of type 1 and type 2, and it's not involved the lungs and another part of the world, of the body.
Hatem, please.
Well, my question was not regarding the fracture. If we were allowed to move on to the remplissage, that's okay. You mentioned that you do 2 anchors. Do you always do that? Have you had any cases that were over-restricted that you needed to take down?
Okay. Thank you for your question. Habitually, I use 2 anchors. Even the literature shows us that it's possible to film the lesion with only 1 anchor, because you reach the objective that is diminish the Hill-Sachs lesion. But I look for the best way to exclude the lesion. And about the range of motion limitation, especially external rotation, is very interesting. The first article published by Connolly that present an explanation about the question that is imposed in our meetings, how to avoid the limitation of external rotation. There is a good explanation by Connolly. This technique don't promote a limitation of range of motion, but limit the humeral head to glide over the glenoid surface. This is very interesting to answer this question, because habitually we can see in all the literature there is no important external rotation limitation. Even there is a most recent meta-analysis published that demonstrated this. I think it's the question.
Any more comment?
Any questions from the audience? Yeah.
I'd like the opinion of the table about a case that I have seen. A patient went for a bunker correction, and what we have seen in the arthroscopic surgery, that the labrum was completely rotten and could not be made the repair, and the shoulder was very infiltrated. The table would choose another day for opening surgery, or would do immediately, having a shoulder completely infiltrated.
Acute dislocation?
No, chronic.
Chronic dislocation?
The labrum was completely rotten because the woman, the lady, had more than 20 years
20 years.
repeated dislocations.
Okay.
So the question is, it's a chronic dislocation and there is no labral tissue to repair.
Yeah.
Yes.
And a very infiltrated shoulder. We would choose in the same day, immediately make an open repair, or choose another day because it's an elective surgery.
Well, first I think it's important to look for the labrum very well, because sometimes, like in Alpsa lesions, it's quite down on the glenoid, not high like the Bankart lesions. So identifying and making sure that it's there is one important step. I've seen your scenario, but only once or twice, and my decision then was to convert to a lateral J.
Okay. I think the same. It's necessary to remember that Lanny Johnson classified 6 types of Bankart lesions by arthroscopy, 6 types. And type 6 is without ligament and without labrum. And type 6 is necessary, of course, a lateral J, because you don't have labrum and ligament in the patient.
And that would be another comment that, for maybe other persons who see this type of multi-dislocator, is that you have this, no more labrum, you reduce, you make MRI. And on the MRI, you study the position of the glenoid, because if the patient is a multi-dislocator, sometimes it's not only labrum disappeared, but also the glenoid is flattened. And if the glenoid is flat, you cannot reconstruct anatomy with the capsular remplissage, whatever. You should do a bone block or a Latarjet. So MRI would be the solution, reduction and MRI.
Any more comment?
Yeah. Here in National Institute of Orthopedic, we have the opportunity to treat patients with their multiple dislocators because of the long line that we have to do surgery in them. And a lot of those patients, they have the capsule more than the labral. There is no capsule, and as been said, our opinion at the same time when we do the arthroscopic, we see that the capsule is very bad, we convert to a lateral J.
I have experienced with few cases like this. When I used a capsuloplasty to fixing the capsule in the anterior glenoid and a special tip. At this moment, I maintain the shoulder in external rotation, maximum external rotation, and I made a subscapularis tenodesis in the lesion. The cases, they went well, and I think this is a good solution. Especially this was used in the past, long time ago, when the use of MRI or even CT scan in Brazil was difficult. So you had to decide during the surgery. And this I can suggest to you as a good option.
I have a question for the panel too.
Okay, please.
Is there any patient that do you prefer the open capsular old surgery as described by Nir, the open capsuloplasty? Is there any patient that fits this indication nowadays?
Well,
the open repair.
Yeah. Now I don't do any more capsular repair open. There are some still surgeons who do open treatment for the capsular shift, when they do capsular shift. Otherwise, I do everything with a scope because I'm more comfortable. I see much better, and I have more place. You know, I mean, you are familiar with the shoulder approach, and when you are on the anterior way and an anterior approach, you cannot do something in the back. So you have to do everything on this way. When you go with a scope, if you have some lesions in the back, you can also address to that lesions. You can make a capsular plasty from the back also. So now I think doing arthroscope techniques is much better for this type of instability.
Hickson first.
Hickson, please.
Thank you. Dr. Gleason, I performed the massage procedure as you show us, but I don't have problems. Nowadays I'm using 2 anchors. I don't have problems with restriction of range of motion, but I have problems with the suture limbs because you use one cannula for the 2 anchors, and nowadays I put two cannulas. How do you manage if you show this in the all-inside technique?
Yes, thank you. I use only one anchor, one cannula, but it's described. This is the possibility to change the technique and use one cannula for each surgery, for each matter surgery. No problem. What I do, I withdraw, as I could say, the cannula from the articular side to the bursal side. And the cannula will be used even as a guide. You introduce a penetrator grasp, and with the cannula pulling the cap, so I can see the position, and I capture the limb. The question, how to do the suture, how to tie the knots into the bursa without seeing the knots. Is this a problem? Burkhardt recommend to see into the bursal side, but almost all other surgeons prefer to do this without direct vision, but visualizing into the joint how is the Hill-Sachs lesion being filled. You can choose, there is no problem to use more than one cannula. Okay?
Any more question?
A question to Dr.
Comment. Okay.
Gleason, maybe you don't said or don't explain so much. Which tendon do you use for lymphisage?
Good question. Because we understand that we are using the infraspinatus tendon, but be sure about this. It is impossible to define the limit of the tendon. Good question. We understand that we are using the infraspinatus tendon.
Try to use.
Can I make a question?
Yes.
Yes, to Dr. Marius. There is a situation where your patient presents a hyper-elasticity, but in a moment he presents a trauma and a typical traumatic event with anterior dislocation of the shoulder, with the Bankart lesion, typical lesion of traumatic event, and sometimes a little Hill-Sachs lesion. So, the question is, when the patient is a hyperlaxity and present a traumatic dislocation of the shoulder, how do you operate this patient, making the correction of the lesion, the traumatic lesion, and at the same time you correct the hyperelasticity, or you think that if the patient was in all his life an hyperlaxity patient without symptoms, why to do it? Do you understand?
I completely agree. But I mean,
both of them or not?
No. I would only fix the Bankart lesion because the patient is hyperlax. So I will not make him happy if I fix everything because he will be stiff. So I make from a patient, you take a contortionist from the circus. He's able to turn his joints wherever, but he's not painful. So if you fix his joints, he loses his job. So it's the same time with the hyperlaxity. He's hyperlax, he's doing Bankart lesion, you fix the Bankart lesion, you don't fix the hyperlaxity.
If he's stiff, no dislocation.
Yes.
This is my
Well, Ehlers-Danlos is different. I mean, we have 8 types of Ehlers-Danlos. I mean, in the type 4D, that's what we call like asymptomatic Ehlers-Danlos, so they have only hyperlaxity. We send them to the genetician to see if something, because some of them, they are really unhappy with all the joints. But I will not change their lives, I will change just the shoulder. Because I will focus on the shoulder thing. I mean, he comes to me because he dislocated the shoulder. He don't come to me because he's hyperlax.
Okay.
If it was like that, he was coming to me before he dislocated.
The last question. The last question.
Yes.
I'd like to ask you, all of you, who did for revision in instability of the shoulder with arthroscopy, only arthroscopy. Revision of instability, only arthroscopy. Okay, open. Okay. Thank you so much for everyone. It was so nice and very, very important.